All right, I think we've had a chance to let everybody join. We'll go ahead and get started. And so for those that didn't hear me, good evening and thank you for joining the Women's Health webinar. We'll start with a few housekeeping items and then I'll introduce today's speaker. First, your participation is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and the speaker. If you wish to ask a question, please type it in the chat box at the lower part of your screen. We'll address all questions at the end of the presentation. I'd like to take a minute to introduce our guest speaker, Dr. Brandy Hood. Dr. Hood was born in Mississippi, where she completed 2 bachelor degrees at Mississippi State University. She then attended the University of Mississippi School of Medicine in Jackson, Mississippi. She completed her urology residency from the Wake Forest School of Medicine in Winston-Salem, North Carolina. Dr. Hood is a board-certified urologist and has been practicing at Urology Associates of Nashville for 4.5 years. Dr. Hood, we appreciate your time, and at this point, I'll turn it over to you to get us started.
All right, well, thank you very much. Thank you so much for joining us. Tonight, we're going to be talking about incontinence, specifically on stress urinary incontinence. So thanks for joining. I'll go ahead and start. So urinary incontinence is a medical term for urinary leakage or bladder leakage, which basically means loss of control or loss of urine when you were not intending to lose urine. It's a very common problem, actually. About 1 in 2 women have incontinence, so half of you joining us tonight may deal with this issue, and you're not alone. About 18 million people in the US also struggle with this issue. There's a few different types of incontinence. So urge incontinence means incontinence associated with an urge to urinate. Often patients will describe, you know, when I have an urge to go, I've got to get there really quick, because if I don't, I may lose it on the way. Stress incontinence is incontinence that occurs with stress on the pelvic floor, so mostly with activity. That's jumping, coughing. Some of my CrossFit patients notice that they'll lose it when they're doing, you know, exercises at the gym. And then mixed incontinence basically means that you have kind of both problems, some components of each issue. Overall, stress incontinence is the most common, urge incontinence being the least common, although you know, mixed at 29%. As we see women age, and especially after menopause, mixed actually can be the most common type. And so a lot of times, especially in some of my older patients, we are dealing with both issues. That's very common. So as we said, urge incontinence is the loss of urine that occurs when you have an urge to get to the restroom. It's often associated with overactive bladder, which is sort of a bladder syndrome where people feel the need to urinate very frequently. As I said, they don't have a lot of time to get to the restroom. They may leak on the way to the restroom. Often also are getting up a lot at night to go to the restroom. More of a bladder problem, where stress incontinence is more of a urethra problem. It's the loss of urine during movement or, you know, stressing of the pelvic floor, exercise, coughing, sneezing. It has to do with some weakness in the urethra. So 2 types of stress incontinence. One would be hypermobility, which is where the urethra has lost some of the normal supports that keep it, you know, like the tissues and the ligaments that support the urethra, so that when you cough and sneeze, you know, the urethra is held in place and has a backdrop to keep urine from leaking out. With hypermobility, the urethra may move. It may kind of move down as there's downward pressure on the pelvis, and it allows the urine to leak out. Intrinsic sphincter deficiency is sort of referring to an intrinsic issue with the strength of the urethra, whether that's thinning of the supporting tissues inside the urethra or weakening of the sphincter that keeps it closed. You can see here, normally there's a closure of those folds of tissue, whereas when it becomes weakened, it's kind of just open even when it's at rest, when it should be contracted. And so because the urethra can't keep that good closing pressure, it allows urine to leak out. Risk factors for stress incontinence. A lot of things can be a risk factor. Age, menopause, you know, there are changes that happen in the tissues when our estrogen levels get low. The tissues in that area in general get thinner and weaker. Pregnancy, you know, puts a lot of stress on the pelvic floor. It can weaken those tissues. Childbirth, having had surgery in the pelvis, Being overweight puts more pressure on the pelvis. Of course, people that have very active jobs, or as I said, some of my CrossFit patients, anything that involves a lot of aggressive activity, heavy lifting, smoking can be bad for the tissues. And then, genetics. Some people are prone to getting hernias, and they have weakened tissues at baseline, and some of those same issues are kind of related to what causes stress incontinence. So as we said, mixed incontinence is basically components of both stress and urge incontinence, and these patients often either have to pick one to start with or kind of treat both at the same time, and may end up needing to address both issues. So what are the treatment options? Unfortunately, as I said, at least half of you out there watching may deal with incontinence, and half of those people are just dealing with it and haven't really talked to a provider about it, or felt like they didn't need to seek treatment, either because they were kind of embarrassed to talk about it, or someone told them along the way it's just part of aging and that's the way it is. And although it is part of aging and it is very common, it doesn't have to be the way it is. There are treatment options. They range from, easy things you could do at home to bigger surgeries. Everyone's heard about a Kegel exercise, which is basically a contraction of the pelvic floor. It's kind of like, building up the muscles when you do curls with weights, you're building up your biceps muscle. Kegel exercises are intending to build up and strengthen the muscles in the pelvic floor to kind of help re-support the urethra where that support has been lost. For some patients, they have a really difficult time understanding what is a Kegel, or identifying those muscles and knowing if they're really doing a Kegel or not. And so sometimes we'll send people to therapy to help, with a trained pelvic floor therapist, work on physical therapy, work on Kegels, and even some biofeedback exercises to help you know what actually is a Kegel. Am I doing a Kegel? There are actually some treatments now that will help you do a Kegel. I know there's some commercially available, the fancy shorts or a little probe that will help you contract your pelvic floor. We have one in our office that uses an electromagnet kind of to contract the pelvic floor for you as an alternative to doing physical therapy. A vaginal pessary is basically an insert that goes into the vagina that puts pressure up on the urethra, basically like a non-surgical version of a sling or supporting structure. It's something that can be worn a lot of the time, or something that you just insert with activity. There are some made specifically for that purpose, and those would be sort of your, I'm not ready for surgery yet, or I need to think about it and I just want something to kind of help me out right now. There are minimally invasive surgical options, and I would say these are probably the most common treatment options that people elect for. That would be injecting of bulking agents into the urethra to bulk up that interior, and then the sling, which is the surgery where you put the little mesh under the urethra, what a lot of people think of when they think of treatment for stress incontinence. There are some more, more invasive, sort of more aggressive surgical procedures that have been done historically. Bladder neck suspensions, those two, Birch Coppola suspension and the MMK procedure, those involve actually an incision in your lower abdomen. And honestly, most people don't really do them anymore because they don't work as well as the sling and are more surgery, more recovery than the minimally invasive options. So those are used in very rare, specific situations. So mixed incontinence, as we said, components of both. Basically, we have to pick which one is the biggest problem and kind of start there, or in some cases, we may address them both at the same time, but same treatments apply. Who can treat stress incontinence? Really, there's a lot of overlap in who treats stress incontinence. Some general practice doctors may prescribe you medicines for certain types of incontinence. Urologists and urogynecologists, there's a lot of overlap there. Basically, you want to find someone that does this surgery and has training to do it. So what can you do about incontinence? As we said, a lot of people have this problem, but they put off getting treatment for it. And so I would encourage people to, if you have a physician that you trust, talk to them about the options, or getting referred to someone who can treat the problem. There's a lot of information out there on the internet. Boston Scientific has this website, Choose You, which is basically walk you through all the different types of incontinence, what the options are. And so I would encourage you to seek out treatment.